F-I-K-O-A. Fong, F-O-N-G.
Okay. And where were you born?
I was born in Sacramento, California, but moved to Hawaii when I was about 1 month old.
Okay. So where did you grow up?
In Honolulu, Hawaii.
Okay. And I'm going to ask you education before I get into training, but before we start, what is the topic of your testimony today, just in general terms, so we have an introduction for the jury?
Well, from what I understand, I'm talking about a patient of mine named Terry, who sustained a concussion and subsequent post-concussion symptoms after an injury in February, I believe, of 2016.
Okay, thank you. Please describe your education, starting with high school.
Well, I graduated from Kamehameha High School. That's K-E-M-E-H-A-M-E-H-A. I graduated in 95, which dates me. I went straight to BYU, where I did my undergraduate work. I also did a master's and a PhD here at BYU. And then went on to my internship residency at the VA hospital in Salt Lake City.
Okay, and at the BYU, what was your graduate degrees in?
So I obtained a PhD in clinical psychology with an emphasis in neuropsychology, and my field of study was EEG and fMRI.
Okay, now I'd like to get into your training. Can you describe your training in psychology?
Sure.
And how many years? And how many years? I'll let you go ahead.
So I had an undergraduate degree, which was 4 years. I then entered a master's program, which was 3 years, and then matriculated into a PhD program, which was 5 years. I had the opportunity to be the only neuropsych emphasis student. So I got to train with one of my mentors, Dr. Aaron Bigler, one-on-one for much of my training. Also other professors in neuroscience. So it was a really wonderful program that allowed me a lot of one-on-one time with these great mentors of mine. I graduated, well, I finished my dissertation and then went off to internship. And I did my internship, like I mentioned, at the Veterans Hospital here in Salt Lake City, right in 2007 and 2008, which you may recall was right during the Iraq and Afghanistan war, so OIF and OEF. And that's where I gleaned a lot more of my concussion training.
Okay, and
Your Honor, would you explain what we're doing here?
Sure. There's portions of the transcript that don't need to be read in court openly, so they'll be skipping over some of that.
any other hospital or clinical work that you haven't already mentioned? Can you tell?
In that edition.
Okay, and any other hospital or clinical work that you haven't already mentioned? Can you tell the jury?
Sure, yes. So this is my 18th year working for Intermountain Healthcare as a neuropsychologist. I started there in neurotrauma rehab, which really was focusing more on inpatient severe and moderate traumatic brain injury patients. And we had a wonderful multidisciplinary team there, but I did neuropsychological assessments on patients in the hospital and also in the outpatient realm. And I'm still working for IHC. I've been able to help open 2 concussion clinics for IHC, one at Utah Valley Regional and one at American Fork, where I'm still working part-time there. I also work for, I have a clinic here called Cognitive Effects, which is a clinic where we cater to, and we specialize in chronic, persistent post-concussion symptom patients. And then I also have a clinic called Neural Effects, which is located in Provo as well, and we cater more towards the acute, newly injured patients.
Can you explain to the jury the types of TBI victims that you've treated and dealt with in your career?
Sure. Earlier on in my career, I really focused on moderate and severe traumatic brain injury. So these are patients that, either needed neurosurgery or they had a skull fracture or some type of bleeding in the brain, and they were typically in a coma for part of it, whether it was medically induced or part of the traumatic brain injury. I then also moved on to seeing more of the mild realm. So I've actually seen the whole spectrum of traumatic brain injury, but I have stayed in this mild traumatic brain injury realm, which is synonymous with concussion.
What does mild mean in mild traumatic brain injury?
So by mild, we don't necessarily mean the symptoms are mild. What that means is that it's not life or death, okay? So we're not dealing with someone that needs, a shunt placement. We're not dealing with swelling and that we need to remove part of the skull. When the term mild was given, it really just meant that this is a patient with a closed head injury, right? But did not need surgical intervention of that type. So that's where the term mild comes from, but the symptoms can be very, very serious for a patient with concussion.
Hey, you mentioned Aaron Bigler. Can you describe for the jury who he is and what you did studying under him?
Sure. Aaron Bigler has been the president of both of the neuropsychological associations. He is probably the most renowned neuropsychologist because he pioneered this marriage between neuropsychologists and advanced neuroimaging. He has been instrumental in creating and helping mentor other neuropsychologists that have also gone into other types of advanced neuroimaging fields. He's just, I think, probably the most prominent, if not one of the most prominent neuropsychologists to date, internationally.
Okay, let's talk about the clinic. Let's see, in your professional specialties and interests, there's, children, adults in general, and concussion victims. If you could describe that.
Sure. I specialize in the entire age range of concussions. Here at Cognitive Effects, for example, we treat people really between the ages of 8 and 99. At Neural Effects, we see people of all ages, even babies and toddlers. And at American Fork Concussion Clinic, we also see people of all ages.
Okay, and then about your clinic or work, what is it and how long has it been around?
Okay, so again, I have 2 clinics, but I think the one in question would be Cognitive Effects, since that's where I treated Terry. We've been around here in Utah for about 8 years. Prior to that, our first opening was actually in Boston. It wasn't here. We were getting this one off the ground, but the first clinic we opened was in Boston in partnership with Tom Brady, who was, he played for the Patriots at the time. But he and one of his trainers opened up TB12, which stood for Tom Brady and his number 12, but it was TB12 Sports Therapy and Concussion Clinic, and we were the concussion arm of that clinic there. And so that's where it all started, and then 2 years later we opened here in Provo.
Okay. How many employees are at your clinic?
We have about 70 to 75 right now, employees.
Okay, and what types of employees? Let's say starting with the MDs and PhDs, the doctors.
So we have a variety of MDs. We have a neurosurgeon, who's one of my partners, Dr. Lynn Gaffane. We have Dr. Bruce McKiff, who is our in-house neuroradiologist. We have a doctor of nurse practitioner. We have a PhD. We have PhD neuropsychology. We have several PhD clinical psychologists. We have physical therapists, occupational therapists, neuromuscular therapists, cognitive therapists, speech language pathologists, vision specialists, vestibular specialists, neurosensory integration specialists, sensory motor specialists, and so on and so on. I'm sure I'm missing some, but we have all of these therapists that are licensed all in-house, and we are able to do a very intense, multimodal, multi-factored boot camp program here, which caters to these much more chronic, difficult cases.
Like Dr. Sanderson's, Terry Sanderson's?
Yes, correct.
Okay. Before I get to that, Terry Sanderson, the plaintiff, what about the equipment at your facility or your clinic?
Are you referring to the MRI machine that we have?
Yes.
Yeah. So, yeah, we have a 1.5 Tesla MRI machine in-house, which makes it really convenient to be able to scan these patients before and after treatment, sometimes in between treatment weeks as well, to track recovery, to track severity.
When you say recovery, do people recover completely in a clinical setting such as yours?
You know, we definitely have some people that recover completely. They will report they recover completely. I'd say that comprises of about maybe 15% of our patients. About 85% will say that they have significant improvement, but it is a brain injury, and sometimes these effects can be lifelong.
Okay. Let's.
Oh, we lost you, Lawrence.
Oh, you. Okay, you.
Can you hear us?
Lawrence, can you hear me?
Okay, yes. I can hear you. You guys are all fine. I don't know what's going on.
Oh, yeah, we
Can you hear me
lost
now?
you for a long time there, so you'll
Okay.
have to start that question over.
Okay, where do your patients come from?
They come from all over the world, actually. I'd say maybe about 25% of our patients are from Utah, but 75% come from all over the United States. And, well, no, I'd say about 65% come from the rest of the US, and another 10% come from all over the world. We typically have, on average, about 4 of our 20 patients here, 4 of our 18 to 20 patients coming from Europe, or, you know, we have some from Israel, from Asia, from Canada. So it's a really kind of a United Nations here during our treatment weeks.
Doctor, can I interrupt 1 second? The camera is cutting off the top of your head sometimes. There you go, that's better.
Okay.
Thanks. Okay.
Okay. Now, at your clinic, as you earlier described that you cover all sorts of patients. Can you explain what a closed head brain injury is?
Sure. A closed head brain injury typically means it's a non-penetrating injury. So it's an injury that where there's no skull fracture, but there's like a jolting or kind of a rapid kind of force movement that has the brain, here shaking inside of a skull. But a closed head injury means that there was no penetration of the skull into the brain, and no skull fracture.
Okay. And What is an mTBI?
An mTBI is considered a mild traumatic brain injury. And as I mentioned before, mild doesn't mean the symptoms are mild. Mild is just in reference to being juxtaposed to moderate and severe, which mean more of a bleeding in the brain or more kind of organic neurologic findings. So mTBI is synonymous with concussion because a concussion actually, as part of the diagnostic criteria, has no findings on structural imaging, and that means CT and MRI.
And what is PCS or post-concussion symptoms?
So PCS is the name of the complex process that occurs when a patient has been struggling with concussion sequela over a long period of time. In fact, there are different kind of categories of post-concussion symptoms. If you have symptoms for more than 3 to 6 months, for more than that, you can be categorized as persistent post-concussion symptoms or persistent post-concussive symptoms. So what this is just a patient that has concussion symptoms past a certain amount of time, and in Terry's case, by the time I saw him, he was struggling with these concussion symptoms for almost 1.5 years.
Okay. And so are these names closed head injury, mTBI, post-concussion syndrome? These are the symptoms that Terry has?
So, yeah, these are different, I guess, names of different diagnoses that he could have. He had an mTBI, which is a concussion, but then you can also have PCS because that comes like in a timeline after someone gets an mTBI. But yes, he was diagnosed with a concussion and mTBI, and then also with the sequela, which is PCS or persistent post-concussive symptoms.
Okay. What are the risk factors for harmful consequences from a concussion?
Risk factors. Okay, so I think what you're asking me are there certain things that a person can go through or have that could increase their chances of having more issues with concussions? Is that what you're asking?
Yes.
Okay, yeah. There are definitely risk factors. There is a study that was done by one of my colleagues, Michael McRae. It was one of these seminal studies that actually pointed out that there are several what we call risk factors that can lead to a more complicated recovery and a more complicated presentation of symptoms. In Terry's case specifically, he met several of them. One was he actually had a prior diagnosis of anxiety and depression. And so having a prior mental health history is one of the big risk factors for PCS and persistent post-concussion symptoms. Another one was migraine history. So if someone has a history of headaches or migraines prior, that is also a risk factor. And another one was some of the structural brain findings that he had as well. I think it was called normal pressure hydrocephaly. Those are also some risk factors for post-concussion symptoms.
In Terry's case, what do risk factors mean?
Well, in Terry's case and in other patients' cases, it means that puts them at a much higher likelihood to have this complicated presentation and this complicated recovery. It's just harder for them to recover, and their symptoms can last longer and feel quite debilitating. So,
in your opinion, Terry has persistent post-concussion syndrome or symptoms, in your opinion, has he recovered, or will he ever recover?
Terry came to my clinic, about 2017, so a little under 6 years ago. And he worked so hard, he really, gave his best effort, and he did notice, and we noticed some definite improvements. But talking to him now, knowing where he is now, it is still showing clearly that he's still struggling. And so, I mean, if I have a fault, it's that I am an eternal optimist, and I always, want to keep treating and keep working, because I know neuroplasticity is real. But, I think we're getting to the point where he's 76, and I do worry that some of these issues may be long-standing, but I still have some hope.
Okay. Let's talk about your process at your clinic. You do a clinical interview. Can you explain why and what that means?
Sure. So before one of the very first times that I met with Terry, I sat down with him and we went over what we call a clinical interview, and that is information gathering. I'm trying to assess what happened to him. I want to know what his symptoms were like. I wanted to hear about the injury that occurred. And so it's a really good way to gather information and to get a really good history of the patient. I'll ask about psychiatric history. I'll ask about some prior medical history. I'll ask about some prior concussions as well. And so it allows me to assess what's going on and to then have a clinical diagnosis based on that clinical interview.
Okay. When you first met with Terry, I think it was August of 2017. Does that sound correct?
That sounds correct, yes.
So that was about a year and a half after the ski crash that is the subject of this case. And what was his diagnosis at the time when he came to your clinic?
Well, he already came with a concussion diagnosis, right? And it was my job at that point to confirm that. I felt that he did meet that criteria, but I also was able to list out a year and a half later, or 15 months later, what symptoms he was still struggling with. And for me, what's most important is if those symptoms were things that I thought that I could treat or that I could help him with.
Is self-reporting and clinical questionnaire, like in Terry's case, how normal is that in assessing neuropsychological issues in the medical community or the psychological community?
So, very common. In fact, most of the time, by the time a patient gets to me, they've already had diagnoses from several other clinicians, right? I mean, usually a neuropsychologist is not their first person they go to, okay? But, really, as a clinician, the best way to ascertain if someone has a concussion is to ask them questions. We have some different types of tests that we can do as well, like balance tests and vision tests that we can do with them, which are very easy to do and can be done, very quickly in a clinical setting. But yeah, for the most part, it's talking to them, talking about what symptoms they have, when these symptoms started, and really identifying kind of an inciting event or a cause for what happened and when these symptoms started to come about.
What sense do you have, or any evidence do you have, that Terry might have been malingering, exaggerating, or faking his symptoms?
None whatsoever. Terry showed up to every appointment on time. He gave his best effort. The treatment that we do is very, very intensive. So it required Terry to show up every morning on time, to give his best effort in every single therapy appointment. And we're looking at, in a given week that he was with us, 32 hours of therapy, all right? He was an ideal patient. I got to see him every day while he was here in treatment and got to follow up with him and connect with him. And there was no issue with any of our therapists that he was in any way malingering or faking this. In fact, it was almost the opposite. Terry is, a very, very intelligent man, and he didn't want to be injured. I mean, I think that was really clear. It was he's someone that doesn't want to be sick, and was willing to do everything he possibly could to improve where he was at.
Thank you. What is your understanding about his concussion in the ski crash of February 26, 2016? I mean, was the ski crash a cause or the cause of his concussion?
Objection leading.
Okay, I'll rephrase. You're familiar with the ski crash of 2016 he was in February, right?
Correct?
What are, I'm getting at your preliminary opinions at this point. What significant problems was Terry suffering from, in your opinion, from this ski crash of 2016?
Well, he was reporting a myriad of symptoms, including cognitive issues. So, he wasn't, he was fatigued. He wasn't thinking as clearly as he was before. He reported some issues with mood, personality changes, pain as well, headaches, and so on.
And how significant were these problems, in your opinion?
Well, I mean, according to Terry's report, these were quite significantly affecting his life. I mean, it was affecting his personal life, his family relationships, his friendships, his ability to, have self-confidence. He was further isolating. He just it affected him on so many levels, especially for someone that was used to loving life and enjoying life and traveling and all that. By the time he came to me, that was pretty much gone.
Okay. Oh, I think I was mistaken. Maybe you saw Terry first in May of 2017. How significant I guess what I'm trying to get at is, how can a person with high average or superior scores on testing still be impaired by a traumatic brain injury and suffer persistent concussive symptoms? Can you explain that, please?
Sure. I think what you're referring to is, I know that he completed a neuropsychological evaluation. I believe maybe at the VA hospital. Does that sound right? I don't want to misspeak.
Yes, maybe that's it.
Yeah, and in fact, I know who, Dr. Madsen, I believe, and she was there when I was doing my residency at the VA. She's a wonderful neuropsychologist. What we have, when we deal with concussion patients, okay, we have seen that, especially if they are intelligent or if they are at a higher level of functioning, which, I would assume he would be, considering his education level, him being an optometric physician, you would assume that he's functioning rather well. So with these patients, often the neuropsychological, like paper pencil tests that they can do are not sensitive enough to pick up some of the challenges that he's having. In one sense, maybe his functioning was up here prior to the accident, and then now he's down here. But if everyone else is down here, he'll be kind of in the average, maybe high average range. But, we could assume maybe he was in the superior range prior to that. And so we often see cases where neuropsych testing or neurocognitive testing can be totally normal, but the patient can still have a concussion. And in fact, one of the best
The blank out is intentional.
concussion and brain injury, where to get help. And it says about concussion, it's entitled head, excuse me. We'll be sending this to you right now in the next minute or two, Jane.
I apologize for the difficulty and interruptions. In the old days, we used to just read this to you, so this is much preferable. I guess the old days wasn't that long ago, was it?
Judge, we're about 45% through. Is it, do you want to take a break or just keep going?
How are we doing right now? We can keep going right now? Okay, we'll keep going.
Right now. I'd like to talk about, in particular, Terry Sanderson's case. It's my understanding you recommended that he travel. Why did you recommend that he travel?
So when he completed the boot camp with us, part of what he said that he missed and part of what gave him so much joy was traveling. You know, and as someone like Terry, who I actually really love to travel, right? In fact, as you know, I'm heading to Europe for work to present at some conferences internationally. I encouraged him to try to get back to doing things that he loved. I did caution him that he should not travel alone because of his memory issues and other problem-solving issues. But I did strongly recommend that he try to get back to doing things that he enjoys, and that included travel.
So, can you how would you describe the treatment then that he's received at your clinic?
So the treatment was very intensive, very targeted and focused to those particular regions, right, that we saw. And it is a boot camp. I mean, he was here with us for a full week. He participated in no less than 32 hours of therapy, and then the rest of those hours were filled with before and after imaging, right? Yeah, he was very compliant, but every day he had at least 1 hour of cognitive therapy, speech therapy, occupational therapy, physical therapy, neuromuscular therapy, vision, vestibular, and even psychotherapy, right? I mean, you cannot extricate some of the, the depression and anxiety aspects because he suffered from that beforehand. So we made sure he got some of that here in treatment as well.
Hey, Lawrence, if I may, I'm just noting that if she has to leave at 3:30, there's only an hour left, and I have an outline of like 10 pages. So it's going to be tough for me to get through without the rest of the time here.
Okay, we'll try to go quickly. Thank you, Doctor. What are some of the recommendations that you've made after this treatment for Terry in terms of his regular life or outside of the clinic?
I believe I listed my recommendations on a report that was on actually Exhibit 33, if you want to share that one. I have some recommendations on there. I don't have it right in front of me, but, you know,
I'll share it real quickly.
okay,
It's not in color. Do you
that's
remember-
okay. Just go all the way up to the top. Keep going. Okay, so right here, actually, if you go down, so these are some recommendations. I recommended some massage therapy. I know that he was seeing a therapist as well, and I recommended that he continue to do that. If you scroll up again, keep going up. Let's see. Oh, I'm sorry. Go down right here. So post-epic treatment report.
Sanderson had a concussion on or about February 26, 2016,
Yes, it is.
and that resulted in a TBI.
It resulted in what we consider an mTBI. Yes, a traumatic brain injury.
Judge, just 1 second. We're gonna try to find out if we skipped ahead too far.
Page 51, line 12.
51, line 12.
She just read 11.
So we can back up.
No, psychotherapy. I recommended.
There's psychotherapy in there. This was okay.
Let's see. Oh, I'm sorry. Go down right here. So post-epic treatment report recommendations. You know, he's still
That's it?
reporting balance issues, dizziness, mental fog, feeling slowed down, difficulty remembering, irritability. And so I recommended, psychotherapy. I recommended some additional cognitive and occupational therapy, as well as neuromuscular therapy.
Okay, and these are pages 6 and 7 of the 87 pages of Exhibit 33. Okay. So is it your opinion that Dr. Sanderson had a concussion on or about February 26, 2016?
Yes, it is.
And that resulted in a TBI?
It resulted in what we consider an mTBI. Yes, a traumatic brain injury.
And the cause, he self-reported that his injuries were caused by a ski collision on February 26, 2016.
The wheels kind of fell off the truck for him, so he reported that he was functioning fine.
I didn't want to make an objection in the middle of all that, but I just want to register for the record that we object that. For treatment, it sounds like it wasn't related to treatment, but I just wanted to get that on the record.
How are your opinions changed since your deposition? Have they, how have any of your opinions changed about Terry since his deposition?
I don't think they've changed at all. If anything, I fear that.
That's the part right there that you should pause it. And you can pop ahead to line 17.
Experts, including two neuropsychologists, Dr. Eastfold and Dr. Austin. You've reviewed the defense's handpicked experts, including two neuropsychologists, Dr. Eastfold and Dr. Askenazi. What are your responses to their opinions, or at least in their reports?
I mean, they have a lot of opinions in their reports. But again, I want to just emphasize that there's a really big difference between going over someone's chart in another state across the world and actually having that patient in front of me, you know, dejected, crying, helping them. You know, I think it's really easy to criticize someone from that far away, and it's a totally different beast when you're in the trenches with that patient trying to get them out. They have a lot of opinions that I think show that they are not concussion experts, that they are not traumatic brain injury specific persistent post-concussion experts. And I think if I'm being totally honest, a lot of their opinions are easily refutable, if not most of their opinions are easily refutable by just going online and looking at, you know, the CDC recommendations for clinicians and how to treat concussions.
Okay,
With all due respect, but, you know, I mean, they do not, I just do not think that they're seeing him as an individual and as someone that is really suffering and has suffered and has done everything in their power to try to get better.